presenting a bit of detail and a bit of insight on what we know already on motor homunculus and a bit of representation of the intercostal muscles that we were able to delineate in the cortex and the subcortex. So the introduction, as we are all aware, that the paper from Penfield in 1937 with that 55-page long paper with all the details about representation of the various body parts, now which we know as the homunculus. So in our series here, we collected some data on the findings during the subcortical and cortical stimulation during tumor surgery on the eloquent brain of the intercostal muscles. So for all the patients who had tumors in these regions, we utilized MRI, preoperative TMS, DTI, along with the cortical and subcortical mapping during the theaters with strip electrodes, with monopolar stimulation, as well as the continuous probe stimulation. Along with that, we had the provisional histology provided during the procedure for the resection of the tumor. So this is the table of 6 patients where we were able to collect the data on stimulation of intercostal muscles, both in cortex as well as the subcortical region. The first patient was an incidental finding from where this study started. So the first patient, the neurophysiologist observed contraction of the intercostal muscles and the diaphragm where we were stimulating subcortically, and then this study began after that. We didn't take extra time or extra stimulation to record specifically intercostal muscles, but this was some finding that were observed during routine stimulation. So here we can see 6 patients, 2 on the left, most of them on the right side, SMA or parietal lobe, with various different histopathology ranging from glioblastoma, even one case of radiation-induced vascular malformation, which was quite rare to find, where we were able to stimulate both cortex as well as subcortex with different milliamps of 6 and 14. 2 of the patients did not have TMS, but the rest had preoperative navigated TMS. So these are an example of 2 patients here, patient 1 and patient 4. Patient 1 had a SMA, a right-sided lesion, and the patient 4 had left-sided precentral cystic lesion, where we studied these stimulations. So in this diagram, we have patient 1, where we were not able to get the cortical stimulation, but in patient 4, we got cortical stimulation in the numbers 1 and 2 for the intercostal muscles. Going subcortically in patient 1 and patient 4, we had both cases giving us stimulations for intercostal muscles. So in the patient 1 data in TAC 6, we were able to get the intercostal muscles very discreetly without involvement of any other areas of the corticospinal tract. Similarly, in patient 4, on the 9 tag represented with the black arrows, we were able to get the intercostal muscles subcortically. And this was after tumor resection. So coming to the discussion about homunculus, we all know about it and have been learning about it. It doesn't seem that simple as it is represented in the initial slide that I showed. This is a paper by Prof. Catani in 2017, where he re-studied all the points that were collected by Penfield in his 1937 paper, and then highlighted various areas. So in the diagram, you can see there are cortical body maps depending on the area of stimulation and the number of stimulation, as well as the vertical height of the areas of stimulation. So depending on the 3 different areas, there were 3 different sizes of the homunculus. So B for B and C for C and D for D is per the 2 different diagrams. The A picture down below is the diagram that we generally see for the motor homunculus, which I think is not really representative of what the data showed. We have further studies now that we know that there is a lot of overlap between different parts of the body, which is a bit different from what is represented from the initial homunculus diagram. So from Coutesy paper in 2017, also from paper from Farrell et al. In 2007, and the 2018 paper, which has highlighted that it's more of overlap between different body parts, going up to 4 different body parts in the same area, providing signals through the corticospinal tract. So there are further papers which also give us an idea about there is more to the somatotopy, not just with a constant homunculus, but more of a dynamic somatotopy, where there is change in the representation and change in the signaling in the corticospinal tract when you do different movements, for example, flexion and extension. So there is overlap between signals between the post-central gyrus, pre-central gyrus, and the central gyrus, which gives us a very dynamic picture of the corticospinal tract itself. Similarly, in the second this slide, we have more representation and more overlap going back to the parietal cortex and going in front to the SMA, rather than limiting itself to the motor cortex only. Further papers which now highlight that there is difference in the representation in the subcortical region as compared to the cortical region, where you can see the turning of the corticospinal tract and different directions in terms of vertical, transverse, lateral, and anterior. So this is our first case series, and we were able to locate the intercostal muscles cortically as well as subcortically, which corresponds to the previous description of the homunculus. And we also wanted to see if there is any evidence in monitoring and preserving the corticospinal tract representing the intercostal muscles, which might prove some benefit in preventing postoperative mortality and morbidity in terms of the chest infection and infection of the lungs. So we published this result recently in Brain Structure and Function, and these findings correspond to the arrangement of motor homunculus, and there needs to be further research on this topic. So I just want to put this last question before I finish, that is it time we should revise the initial paper on Penfield? Thank you.